Could everyone take their seats? Thank you, Karen, for the introduction, and thank you, everybody, for inviting me. This talk will be incredibly basic as opposed to the wonderful basic science and research talks that you heard earlier this morning. I'm going to share a few of my thoughts on the surgical management of EB. So first, as you've already heard, and very simplistically, there are basically three large categories of EB. The first, generally mild, is epidermolysis simplex, which involves lysis in the epidermal layer of the skin and results usually in minimal scarring. The second broad category, of which there are many subcategories, is junctional EB, and this form of epidermolysis bullosa in general is considered lethal, although there is some new data that hopefully will improve this condition. The condition that I'm going to speak primarily about is dystrophic EB, which is blisters which occur in the papillary dermis, which is deep to the basement membrane, that center lamina lucida, and this can result in severe scarring. So what happens? And I'm a hand surgeon, so I'll be talking exclusively about problems in the hand in patients with EB. First, the thing that happens is there's trauma, usually of a frictional nature. This results in cutaneous blistering. The blistering leads to scar formation, and the scar formation ultimately, because of repeated episodes, results in contractures or bending of the fingers and thumb, stiff joints, and skin which is very non-pliable or mobile as compared to a normal person's skin. I'm going to talk primarily about three different types of hand deformities. The first is pseudosyndactyly. Syn means together, dact means digit, so this is a digit which is webbed together. This is pseudosyndactyly as opposed to congenital syndactyly. That would be someone who was born with two fingers or more that are webbed together. Secondly, I'm going to talk about thumb adduction contractures. This is when the thumb is drawn towards the index finger so that the individual cannot grasp large or small objects and has difficulty with pinch and fine motor coordination. Then I'll discuss the surgical management of digital flexion contractures, where the fingers bend down sometimes into the palm. And finally, I'll mention acral, which means towards the end, or distal, osteolysis, which means dissolution of bones, so that normally each of our fingers has three bones in it, a proximal, middle, and distal phalanx, and over time there's loss of the distal phalanx and sometimes even the middle and occasionally the proximal phalanges in EB. So again, we're having a little trouble with our computer slides here, but the first deformity is the so-called pseudosyndactyly. This results when there's repeated scarring, in this case between the index and middle fingers, such that the two fingers are completely joined together because of scar formation. The second problem is acral osteolysis. Again, this is loss of the end of the finger. Most children with EB, my understanding is, are born with a small fingernail, but over time early in infancy, this goes away, and even further over time. Oftentimes, the bone at the end or distal portion of the finger will resort. Next are flexion contractures. In this case, you can see that the fingers are fixed at a right angle at what is called the metacarpophalangeal joint, where our large knuckles are. And oftentimes the more distal joints, these joints in here, so-called proximal, PIP, proximal interphalangeal joints, are also flexed. Finally, a very difficult problem in any type of hand surgeon's practice is the adduction deformity, whether it be a result of EB or a result of a post-traumatic condition, adduction contractures, where the web space between the thumb and index fingers is narrowed, making it very difficult to pick up cylindrical objects or do fine motor manipulation. What's the worst case scenario in EB? This is, in my opinion, the so-called cocoon hand, and this will result in some patients with EB who have undergone no treatment. So basically, there is loss of some bone, but the entire hand becomes encased in a cocoon of skin. Secondly, it's very important to understand that surgery is not a panacea in any way, shape, or form. Recurrence is inevitable. This has certainly been my experience. And as all of you know, infections are a terrible problem in EB, and long term, there's a high risk of developing squamous cell carcinoma. Here's a patient that has a cocoon hand. One cannot see any of the fingers, but interestingly, if you look at the x-ray to your right, most of the bony structures are still there. And if we had a video, we could actually see the fingers moving within the hand. So the muscles and tendons which work the fingers are still functional. Fortunately, this child had an opposite hand, and there's an expression in hand surgery: if you have a little, that's a lot, and this patient had a thumb and enough to be somewhat functional. Here are some of my thoughts regarding the operative management of EB with respect to the hand. Our primary goal, at least in my opinion, is to restore pinch and crude grasp. So again, my focus in the treatment of these individuals is to try to get a broader thumb index web and try, if possible, to create a mobile index finger. Secondary goals are to restore the posture of the hand. So many times the fingers are flexed or bent into the palm, and with some patients, parents permitting, patient permitting, we'll straighten the fingers out to improve overall use of the hand. But this is generally, in my opinion, much larger surgery. Finally, all of the digits can syndactylize or join together, and another goal for independent finger motion may be to release the so-called pseudosyndactyly. What about the timing of surgery? Very unclear to me. Since I'm not the primary caregiver, it's usually when a patient shows up to see me, and certainly the presence of EB does not equate with necessity to surgery. These are very, very, very difficult decisions, and I would never in any way, shape, or form try to twist someone into having surgery. With the wonderful anesthesia that we have today, though, surgery can be done safely at quite an early age. But again, This is a shared decision with the EB team in Cincinnati with Dr. Lucky and her colleagues, myself, and above and beyond everything, the family. Considerations, if you do go to the operating room, are that it's critical that there be an excellent line of communication between the nursing staff, the anesthesiologist, and the surgical teams. I'm fortunate to be able to operate at Cincinnati Children's Hospital, where there's a huge reservoir of expertise in the management of these patients, both as an outpatient and in the operating room, and this communication is very important. Protecting involved areas of the skin, the eyes, the airway, everything, all important. Everything has to be carefully padded, and we use special coagulation for bleeding. So this is a patient with EB on an operating table. The anesthesiologist has already inserted an airway. Sometimes when I'm doing normal cases, I'm kind of pacing to try to rush the anesthesiologist. This is one situation where I leave the room and don't show up until everything is stabilized. The airway, of course, being far and away the most critical part of the operation, not those little precious hands. The patients at our hospital are placed on special padding. Oftentimes we'll put Vaseline on in addition to try to minimize any type of frictional trauma. I believe even today with all these synthetic types of skin that your own skin is probably the best. And in most of the children that I've operated on with EB, the skin from the abdomen is a reasonably good donor site. Some case examples. This is a patient with rather involved epidermolysis bullosa. There are flexion contractures of nearly all of the digital joints. The fingers are rigid and immobile. And merely by incising across the fingers, we can take those very short fingers, which 5 minutes earlier were flexed into the palm, and we can straighten the fingers out. Usually when that happens, the shell of skin comes off, no matter how careful you are to be with the epidermis. I am a big believer that there are two additional requirements. One is that if you just left the fingers pinned straight out, scarring would recur and the contractures would recur. Secondly, you have to apply a skin graft, and I like what's called a full thickness skin graft, which involves all layers of the skin and contracts less, and then to protect the skin graft and prevent immediate recontraction of the fingers, I use pins for 2 to 3 weeks. Here's the result in this child with much straighter fingers. You can see in the lower left that he can pinch. I've given him one of my seized lollipops, prized seized lollipops, and he can also do some crude manipulation. Here's another patient with severe contractures of the central two fingers, the middle and ring fingers. The tips of the fingers are really in the palm. These are useless fingers at this point. Again, by surgically incising, and one has to be terribly careful because within a 0.5 millimeter you can cut the nerves that supply feeling to the end of the fingers, and if you go another millimeter further, you cut the arteries, so you can lose a digit doing this. We've done the release, put in pins. Note that those fingers that were in the palm are now out straight. We're going to put on skin graft, and then the critical part of the procedure, which is done in conjunction with our wonderful occupational and physical hand therapists, is prolonged splinting, which I'll talk a little bit about, and then ultimately pain removal. Other considerations post-operatively are pain. These are painful procedures. And one thing that we can do, at least for the initial 12 to 18 hours, is we can anesthetize the hand with Marcaine, which is an long-acting anesthetic. We have to be very careful to apply, as all of you know, non-adherent dressings. And I generally will dress the hand from above the elbow, particularly in infants and young children, to the tip of the fingers. So here's a patient that is post-op. Again, special dry goods, Methafil and Mepiplex on the fingers. If we've done a web separation, we have to be sure and put something between the webs, as all of the children that I've seen in the room today have. We're generally not going to do a dressing change for at least 2 weeks, and optimally a dressing change should be done in the operating room also. Sometimes this is not feasible. Then at 2 to 3 weeks after the dressing change, the therapist will make a splint holding the fingers in a functional position. The pins are removed and therapy is slowly initiated. Here's the patient again that had the fingers flexed into his palm. You can see that we've been able to successfully have the grafts take. He can fully extend or straighten his fingers, and he can make a good fist. And below, most important, you see a modestly happy patient and a very happy mother. Here's an example of the so-called pseudosyndactyly release. Here's a patient that has webbing all the way out on all of the fingers. Again, I felt that doing a limited procedure, just freeing up the index finger, was preferable to going for the home run and separating all of the fingers. Here we basically split the fingers. We have to be very careful as we move towards the base of the finger not to cut the artery to the finger, which is tiny in children and even in adults. We then applied a skin graft, put on a bulky dressing. You can see here post-operatively that the fingers are well separated, the splint that the therapist made. And ultimately at 6 months post-operatively, we've got a good separation between the index and middle finger, have a moderately functional thumb so that this patient can independently oppose the index finger and do better manipulation and grasp. Finally, the most difficult thing that I deal with is an adduction contracture, or when the thumb basically goes into the palm and is tightly adherent to the index finger. If you don't have a thumb, or if your thumb is non-functional, it's very hard to do most activities of daily living. This happened to be a very courageous 37-year-old accountant, mother of 2, who couldn't pinch with her left hand. She'd had 2 prior surgeries in an outside hospital. This is a little medical garble, but the bottom line was that she had a bad thumb. And this is a picture of her thumb. So she's an accountant. She's got basically her only useful digit is the index finger, which kind of works like a normal person might have a pencil in her hand using it. And our goal, this is the x-ray, you can see the severe so-called swan neck or Z deformity in her thumb. You can also see that the first line towards the floor is the thumb, so-called thumb metacarpal bone. That's completely parallel to the index finger metacarpal bone. That shouldn't be. They should be at about a 45-degree angle. And then the next bone is dislocated about 90 degrees. No one should be able to extend their thumb to that, and then the end bone is bent down about 90 degrees. So here we have released her thumb by doing a variety of both bony and soft tissue procedures and muscle procedures. And at 3 months postoperatively, I know you look at that and say, Dr. Stern, did you do anything? And the answer is yes. And I will tell you that just that little operation, when you have nothing, a little's a lot. This resulted in a very happy patient. And she's actually, an adult and has come back for additional surgery. So that was a huge improvement for her and a good boost to my ego. Postoperative goals, really important to maintain the gains achieved in the operating room, and this doesn't always happen. Maximize function, maximize range of motion, and again, I take my hat off to the hand therapist because he or she is really the critical person in this postoperative period. Again, as I've said before, I have my patients wear a dressing. Don't do a dressing change for 2 to 3 weeks. The dressing change, again, can be done either in the office or operating room. We remove the various things that we put on and we make a splint. Then in closing, a few observations, and I'm trying to be very honest with everybody. If you go see a surgeon and they tell you they've got the cure, I think you need to get a second opinion. I believe that after surgery, recurrence is usually inevitable, although maybe not as severe. Could you advance? There we go. Delay of recurrence, I think, is somewhat proportional to compliance, both in terms of patient education and seeing everybody in the room today is evident that you're getting tremendous education with respect to this very difficult problem and how the postoperative care is managed. I also strongly believe that this is a team approach consisting of the dermatologist, specialty nurses, surgeons, anesthesiologists, pain specialists, social workers, and of course the family, which I left off. We do need, particularly in the surgical domain, we need more longitudinal studies, meaning we need to look at these patients over time to really find out how effective our surgery is. But I believe, as you heard in the first 3 talks this morning, that the ultimate solutions will be provided by my basic science colleagues and research dermatologists. Thank you for inviting me to speak.